Hello, and welcome to Harmonizing HCC Care with a Multidisciplinary Ensemble, guidance for the era of novel, local regional, multimodal, and systemic strategies. I'm Amit Singal from UT Southwestern Medical Center in Dallas, and I'm here with my colleagues, Dr. Goyal from Massachusetts General Hospital Cancer Center in Boston, and Dr. Pillai from the University of Chicago Medicine in Chicago. Thank you to Medical Learning Institute and PeerView for providing this session, and AstraZeneca, Avio, Bayer, Exelixis, Genentech, and Novocure for providing the educational grants for this webcast. Look out for poll questions we'll be posting during the session. Finally, during this broadcast, we'll answer some questions that you've already submitted, but we also encourage you to ask new questions via the live chat throughout this virtual event. To the right of the video, please click on the live chat button to enter, where we will be available to answer questions live throughout the entire session. On the following slides, you can see our disclosures. And we've prepared some practice aids that you will want to refer to throughout our discussion, so please take a moment to download them before we get started. You can also download the slides and practice aids and apply for CME credit by clicking on the buttons in the left-hand panel or by visiting peerview.com/HCC-live21. So with that, we'll go to our first section, refining treatment selection to optimize patient outcomes, drawing from an expanded portfolio of first-line treatment options in advanced/metastatic HCC. And for this first section, I will be presenting the data. So as many of you know, HCC is the third leading cause of cancer death worldwide. The highest burden for HCC is in East Asia and Africa, largely driven by high rates of endemic hepatitis B in those areas. We have an intermediate incidence and mortality rate here in the United States, but here you can see that the trends are actually fairly disturbing. So when you take a look at the top 15 causes of cancer death over a 15-year period, you see that the mortality for most common cancers is nicely decreasing, including lung, colon, and breast. But over the same time period, you see sharp increases in liver cancer mortality leading the way over this 15-year period. And it's currently projected if these mortality trends continue, HCC will be the third leading cause of cancer death in the United States by the year 2035. So we clearly need to do a better job with this cancer in the near future. Now, when we think of HCC, one of the most notable things, and you'll hear this throughout the presentation, is that HCC in the Western world typically occurs in the setting of chronic liver disease, if not in the setting of cirrhosis. As all of us know, chronic liver disease can be from any one of several insults, including viral etiologies, hepatitis B, hepatitis C, as well as non-viral etiologies, alcohol-associated liver disease, as well as non-alcoholic steatohepatitis. The typical progression here is that you go from having one of these liver diseases, you develop chronic hepatitis, you progress to cirrhosis, and once somebody develops cirrhosis, they have an annual risk of HCC somewhere between 1 to 3% every year. Now, we won't get into this in this talk, but of course, the most traditional pathway to skip the cirrhotic pathway and go directly from chronic hepatitis to HCC has been hepatitis B. And we do know now that about 25 to 30% of NASH-related HCC also bypasses this cirrhosis step and goes directly from chronic hepatitis to also develop HCC. And this is notable because we really are seeing a shift in terms of our epidemiology for HCC from a viral-related disease to a disease mediated by non-viral etiologies, including alcohol-associated liver disease and non-alcoholic steatohepatitis. This is a very elegant modeling study by Estes and colleagues, which actually takes a look at the anticipated NASH HCC incidence in nearly every country worldwide. And it doesn't matter where you live. Over the next 10 years, we expect to continue seeing increases in NASH-related HCC, including over 100% increase here in the United States. Now, here's a figure that I think many of you have seen several times over the last several years. This is a more recent version of the Barcelona Clinic Liver Cancer Staging System, the most commonly used staging system for HCC. I won't go through this in detail, but in short, it's important to remember that the BCLC not only incorporates tumor burden, but also incorporates liver function. As I referenced, these patients typically have chronic liver disease, if not cirrhosis, as well as ECOG performance status. And all three of these things should always be assessed and documented when you're seeing an HCC patient, because all of these are important when thinking through our treatment options. The other thing that you can see on this slide is that if you're found at an early stage, you have curative therapies available: surgical resection, liver transplantation, local ablation, and these are the only therapies that give us median survival over 5 years, if not 10 years. Even though chemoembolization, radioembolization, and systemic therapies prolong survival, and we've seen notable advances in those areas, you're taking a look at a median survival that unfortunately is much shorter. Now, of course, these are concepts that have come about and are more recognized in the year 2021 than they were even 2 to 3 years ago. We have stage transitions where you can actually have responses. So people who start with more advanced tumor burden can be downstaged to earlier stages of disease. Most notably, for example, people being downstaged to liver transplantation. And we have stage migration where patients start with earlier stages of disease, have disease progression, and therefore must be considered for alternative therapies, such as transitioning from local regional therapies to systemic therapies. The other thing that you can see highlighted in that red box there is you can see that we've had notable advances in terms of our prognosis with systemic therapy, as we'll cover today, where we now have a median survival over 19 months instead of 10 months, given advances in the immunotherapy options for HCC. Now, we see that in terms of a treatment algorithm, we have therapies that are delivered by multiple different providers, and we really know that the best treatment outcomes are really when you have a multidisciplinary team, whether this is a co-located clinic or whether this is a tumor board, but you really need everyone sitting together at the table discussing the best treatment option for your individual patient. And there have been multiple studies that have now shown this is associated with improved survival. And so this should be considered standard of care for all of our HCC patients. So like every good presentation these days, this is going to be case-based. So let's start with case 1. Case 1 is a 64-year-old male with a history of hepatitis C cirrhosis, underwent treatment for their hepatitis C, achieved SVR, and then was subsequently, unfortunately, lost to follow-up. So was not receiving HCC surveillance and unfortunately presented 2 years later with abdominal pain. So at this time, he comes back to his hepatologist, and fortunately, because he had SVR, his cirrhosis remains compensated, no ascites, no encephalopathy, and his labs look great. You can see the AST, ALT normal, bilirubin normal, albumin normal, although he continues to have some mild portal hypertension with a platelet count of 97, performance status 0, so fully functional. Notably, his AFP is markedly elevated at a level of 720 nanograms per milliliter, and the hepatologist performs an ultrasound, as he or she should, and the patient is found to have a large liver mass. Patient, because of these positive surveillance tests, undergoes an MRI and was found to have a 12-centimeter liver mass with arterial phase hyperenhancement, delayed washout, so classic for HCC, LIRADS 5, and unfortunately has a metastatic lesion to the adrenal gland. So, good liver function, good performance status, but unfortunately advanced HCC. So, what would you do at this stage? So, can I ask Lipika, Anjana, what would you consider for this patient with advanced stage HCC?
Yeah, from my perspective, this adrenal met makes a big difference in this patient's care. And so one, I would really want to confirm that was indeed a metastasis, because if the patient only had liver-confined disease and a 12-centimeter lesion, they could be a candidate for a curative intent resection. So in anyone that I'm considering starting systemic therapy in, I do a biopsy anyway. So I would biopsy the adrenal lesion to confirm that the patient does have distant metastasis. If the patient does have distant metastasis, this patient would be a candidate for systemic therapy because technically this is BCLC stage C disease with distant metastasis. And especially with that AFP of 722, that also suggests metastasis, I would start atezo-bev in this patient.
I think that's a very reasonable approach. I completely agree with that. The only thing to maybe just to be difficult is that it is a small adrenal lesion, and they tend to grow slowly. And could you, if it's a very compensated patient, could you remove the adrenal lesion, cryoablate it or flap resect it? And could you do local regional therapy if it's truly just a solitary HCC? And I would consider TARE in this patient just to see if they have significant feeding vessels and if they have a lot of shunting. If they don't, and it's pretty clear, I don't think it's an unreasonable option to think about, although it's not the tried and true what we talk about when we think of metastatic disease.
I think it's a great point, Anjana. This is why it's great to talk about these patients in multidisciplinary conference. So indeed, when we talk about these patients in our conference, we would certainly have a conversation with the patient, just as you recommended, of liver-directed therapy to the liver, and then thinking about ablation or radiation, for example, to the adrenal gland, and sharing with the patient that standard of care is X, but certainly going on systemic therapy means you have to come back to your oncologist's office every 3 weeks, get systemic therapy, there are side effects from it, and can we kick that can down the road? And so certainly offering the option of a combined local regional approach is very reasonable. Another approach would be to consider doing systemic therapy up front if they have stable disease, then move to local regional therapies on both fronts, or the opposite, start with local regional therapy, and if the patient has more metastases, then move to systemic therapy.
Yeah, I think this is why I think it's really important to discuss these cases in a multidisciplinary fashion. We can see already from our panel that there's multiple ways to approach this patient. I think once again, sort of the sort of evidence-based approach here would be to start with systemic therapy given the presence of metastatic disease, and this is an area that we've seen exciting advances. And so I do think that this would be a very reasonable option for this patient. The one other thing that we would likely do in our center, prior to considering systemic therapy, is to do an upper endoscopy, as we'll talk about, given the importance of this prior to consideration of atezolizumab and bevacizumab. This would also be a patient who would be eligible for clinical trial setting as well. So with that, I think that, as I've referenced already, we've seen notable advances in the front line of systemic therapy spaces. Just as of a couple of years ago, we were really focused on tyrosine kinase inhibitor therapies, Seraphinib and Lenvatnib. And in this past year, with publication of the IMbrave 150 study, we've now seen atezolizumab and bevacizumab really be the preferred agent for patients with systemic disease or with advanced stage HCC. So, let's talk about the IMbrave 150 trial in detail. This was a phase 3 study which took patients with good liver function, good performance status, but with locally advanced or metastatic HCC, no prior systemic therapy, and randomized them 1-to-1 to the combination of atezolizumab and bevacizumab, so a PD-L1 inhibitor and a VEGF inhibitor, or Seraphinib at its typical dose of 400 BID. Of note, and you're going to hear this a couple times throughout the presentation today, all patients were required to undergo an upper endoscopy within 6 months prior to randomization, given the higher risk of bleeding with bevacizumab. And this is one of the key inclusion criteria for this clinical trial. These are data that were presented initially in the New England Journal and then updated at ASCO GI. And here you can see the updated data from this clinical trial, where we see a significantly improved overall survival as well as significantly improved progression-free survival with the combination of atezolizumab and bevacizumab compared to Seraphinib. You can see here that the median survival in the Seraphinib arm was over 13 months, whereas the median survival in the atezolizumab and bevacizumab arm over 19 months, a significant improvement compared to where we used to be. The other thing that you can see here is that you can see notable responses, so responses greater than 30% or greater in 30% of patients. So this is really a very potent combination therapy and one that significantly improves the survival of our patients with advanced stage HCC. Once again, here you can see the detailed data regarding the response rate and duration of response with a confirmed objective response rate using RECIST version 1.1, so the total treatment cavity of 30%. If you take a look at the enhancing component, even higher at 35%. You can see stable disease in another 35 to 45%. So overall, you get disease control, i.e. either stable disease or responses in over 70% of patients. And these responses tend to be durable, lasting several months, with a median duration of response over 18 months. Now, one of the other nice things about this is that this combination is very well tolerated. When you take a look at the adverse events that happen in 10% or greater, you see very few adverse events that are grade 3 or higher in the atezolizumab and bevacizumab arm. Really, the only AE that stands out is hypertension, and all the other AEs tend to be mild and or rare. Now, even though they're rare, there can be serious adverse events to any kind of immune checkpoint inhibitor, including, as we'll talk about later, any form of immune-related adverse event, such as immune-mediated colitis, pneumonitis, carditis, etc. But once again, overall, the therapy was very well tolerated in this clinical trial. I would argue, once again on this slide, part of the reason why we did not see a lot of GI bleeding in this clinical trial was because of the patient selection requiring an upper endoscopy within 6 months prior to randomization. In parallel with the adverse events being uncommon, we see that the quality of life was actually preserved very well in the atezo and bev arm compared to the Seraphinib arm. So you can see here the time to deterioration of patient-reported quality of life was quite prolonged, over 11 months in the atezo-bev arm compared to about 3.5 months in the Seraphinib arm. So now going back to our patient, once again, Hep C cirrhosis post-SVR, presented symptomatically, good liver function, good performance status, but advanced stage HCC, he's now discussed in the multidisciplinary team format. And really at this time, after being discussed in the multidisciplinary team, once again, like we saw on our panel, it was in this case was a nice, healthy discussion. But at the end of the day, the patient was recommended to undergo systemic therapy. As I referenced, this patient underwent an upper endoscopy given the consideration of atezolizumab and bevacizumab. Fortunately, the upper endoscopy showed no varices, no other high-risk stigmata of GI bleeding, and this patient was then scheduled to see a medical oncologist. So I think in this case, atezo and bev would be a very good option for this patient. Of course, the other thing that can be considered for a patient like this is clinical trials. And even though we've seen notable advances with atezo and bev, we're hoping that we see other advances through some of the clinical trials that are ongoing. So with this, I want to talk about some of those clinical trials that were all that are ongoing and that we're waiting to see data over the next several months. So these trials really are these trials are really focused on two different types of strategies: dual checkpoint inhibition, taking a look at combining two different types of immunotherapy, as well as other trials that are focused on the combination of immunotherapy with our traditional therapies, tyrosine kinase inhibitors. And you can see two trials listed under both of these different strategies. I'm going to start with the dual checkpoint inhibition. And the dual checkpoint inhibition currently is really focused on the combination of CTLA-4 inhibition and blocking the PD-1, PD-L1 pathway. Now, simplistically, I'm not going to go through and teach everyone immunology in the next 20 seconds here, but I think in short, what we see here by blocking both of these pathways is that both of these pathways are meant to activate and keep T cells activated, so those T cells can thereby act upon these tumor cells and help create responses. You can see once again these pathways are independent, where the CTLA-4 inhibitors are really blocking the connection between B7 and CTLA-4, keeping once again the T cells active, where the PD-1 and the PD-L1 is really taking the foot off the brake, decreasing the tumor suppression of the T cells. Once again, both of these keeping T cells active so they can once again cause responses in the tumor cell. So one of the therapy options that has been evaluated is the combination of Nivolumab and Tremelumimab. Once again, combination of PD-1 and CTLA-4 inhibitor. Here you can see phase 2 data taking a look at these at this combination evaluated in immune checkpoint inhibitor naive patients with advanced HCC who progressed on or were intolerant or refused Seraphinib. So over 300 patients randomized to one of these 4 arms. And I think one of the interesting things about this trial is it not only evaluated 2 different combinations of durvalumab and tremelimumab, but also evaluated the combination versus single agent durvalumab and single agent tremelimumab. So what we see here when you take a look at this is that we see that responses were highest in the tremelimumab 300, followed by durvalumab. So the highest dose of the CTLA-4, then followed by the PD-1 inhibitor. And it's very interesting because the tremelimumab was only given as a one-time dose here. So it's really a priming dose of the CTLA-4, then followed by the PD-1 inhibitor here. And you can see here this not only resulted in the highest response rates, but also the longest survival here in the phase 2 study. This was the dose that actually was most of interest moving forward into a phase 3 study, the Himalaya trial. This evaluated the durvalumab and tremelimumab in the first-line setting versus Seraphinib. And so now this trial has given us a press release. We don't know the details yet, but just this past month, we learned that the combination of tremelimumab plus durvalumab demonstrated statistically significant survival benefit compared to Seraphinib in the first-line setting. And we're expecting those data to be reported in detail in a meeting in the near future. But once again, this will likely be another combination which is going to be a major player on the first-line setting here. Another combination in terms of the dual checkpoint inhibition has been the combination of Nivolumab plus Epilimumab. Once again, same kind of strategy, combining CTLA-4 and PD-1 inhibition. You can see very similarly to the data we saw with Durva and Tremi, we see the best responses and the best survival with the highest dose of Ipilimumab, so this highest dose CTLA-4, combined then with the PD-1 inhibition. And so once again, you can see here, the arm A, the Ippy 3, Nivo 1, is the one that is moving forward in terms of not only accelerated approval in the second-line setting, which you'll hear more from Dr. Goyal in the next stage of this talk, but also has been the one that is moving forward in terms of first-line combination studies, looking at this versus TKI inhibitor therapy. And so the phase 3 Checkmate 9DW trial is really taking a look at this combination of Nivolumab plus Epilimumab compared to TKI therapy in the frontline setting. So once again, patients with good liver function, good performance status, but advanced stage HCC. And this is really primary endpoint of overall survival in the first-line setting. We have not seen any results from this trial yet, although we anticipate this coming out in the near future. Now moving to the other set of combination trials that are ongoing, taking a look at the combinations of immunotherapy plus TKIs. We have two trials that are also evaluating this type of therapy. We have the phase 3 Cosmic 312 trial. This evaluated the combination of Cabozantinib, a tyrosine kinase inhibitor, with or without atezolizumab, a PD-L1 inhibitor, versus Seraphinib. And so, this was a combination of interest because it is one of the first TKI, IO combinations that has reported in terms of a press release. And you can see here the press release demonstrated that the combination of Cabozantinib and atezolizumab demonstrated significant improvements in progression-free survival, and there was a trend towards improvement in overall survival, but this failed to reach statistical significance in terms of overall survival. These were co-primary endpoints. We don't have the detailed data from this trial as well. We do anticipate this coming out over the next couple months. And I think once we know the detailed data, we'll have a better understanding of where Cabozantinib and atezolizumab fall within the options in the frontline setting. Finally, we also have the combination of Lenvatnib plus Pembrolizumab, another TKI immunotherapy combination. This has very exciting data in the phase 2 setting, where you can see that this combination actually resulted in responses in 45% of patients and had very durable responses, as well as had a promising overall survival signal that was over 20 months. And so this now has moved on to a phase 3 setting where the combination of Lenvatnib and Pembrolizumab is being compared to Lenvatnib in the frontline setting. Once again, we have not seen data from this trial yet, although many of us are excited to see this, and we will see if this is another trial that hopefully will reveal positive results in the future. Now, I talked about some of the trials that are further along, but there are many other early phase studies that are also going on with immunotherapy combinations that you can see listed on the slide. I won't read these off for you, but you can see that these studies are ongoing in phase 1, phase 2 settings, looking at different combinations. But I think we're going to see many more trials come out over the next several years. One of the other trials that is ongoing is the combination of Cabozantinib, a VEGF tyrosine kinase inhibitor. This was evaluated in a phase 1b/2 trial in patients with advanced stage HCC. You can see there having promising signals from a median progression-free survival and having a median overall survival of 9 months as monotherapy. And this is now being evaluated at a phase 1b/2 trial, looking at this in combination with Nivolumab in the frontline setting. And so we'll have to see basically how this combination progresses once again as this moves on. So now going back to our case, and once again, I referenced this early on the last time I talked about this. This patient once again would be a great candidate for Atezolizumab and Bevacizumab, but could also be considered for one of these many clinical trials that I've referenced. And so if this patient was in a center with a clinical trial, I do think that this would be a very good option for this individual patient given this clinical setting. Now, a question comes up. We talked about, once again, the importance of the upper endoscopy. So let me ask, Anjana Lipika, what would you do if this patient had a recent GI bleed? Would you still consider Atezo-Bev? Would you do something else?
So I think that, a recent GI bleed, regardless, I guess if it's variceal or ulcer bleed, I'd be a little bit more hesitant to start a Bev-based treatment. And technically, I guess, any of the VEGF inhibitors, although we're specifically here talking about Atezo-Bev, it really depends if it is, something that we fixed. It's an ulcer that was clipped or a bleeding vessel versus varices, and whether or not they need ongoing treatment. And, that's where I may consider a different therapy like either a dual checkpoint inhibitor or Lenvatnib or Seraphinib, even though, again, theoretically, I guess there's still a risk of bleeding.
Lipika, anything different that you would do?
Yeah, no, I would agree with Anjana that if someone had a recent GI bleed, I would be nervous about giving Bevacizumab and would consider either dual agent or single agent immunotherapy in that patient. If the patient had something that was treatable, then certainly could consider treating and then going on a VEGF inhibitor in short order.
Yeah. I think that, once again, with this idea of the IM-Grade 150 study, all these patients required an upper endoscopy. Patients with GI bleeding history, particularly variceal bleeding, were excluded from this. And so we don't have safety data for Bevacizumab in this clinical setting. And so this is a patient that I agree with, both Anjana and Lipika, that I would consider another agent for this patient if they had a history of recent GI bleeding. The nice thing is that we do have other therapies that continue to be alternatives in the frontline setting. We have Seraphinib and Lenvatnib that are alternatives in the frontline setting. At this time, all we have is a press release, but to your point, once we see data from the combination of Nivolumab and Tremelumimab, this, at least in theory, would be another option that would be available and, would be a good option to consider in the future in this patient. Based on what we have as of, November, 2021, I think that, in this patient, I would consider, either Seraphinib or Lenvatnib. Once again, these are data that many of the people in the audience have already heard, but these were approved in the frontline setting based on the phase 3 SHARP trial, as well as the phase 3 REFLECT trial, respectively, Sharp showing a significant benefit of Seraphinib versus placebo in the frontline setting, Reflect showing non-inferiority for Lenvatnib compared to Seraphinib, and both of these remain in all guidelines as alternatives for patients that are not eligible for Atezolizumab or Bevacizumab for any reason. So, next question, back to this case, playing the what if game, what if this patient had Child-Pugh B disease? What would you consider in that case?
Among the most robust data we have in Child-Pugh B in terms of prospective data in a trial is the Checkmate 040 study looking at Nivolumab in patients with Child-Pugh B7 or B8, another arm of the same study that you shared with Ippy-Nivo. And in that study, it showed that the hepatitis, the rate of, hepatic TRAEs was actually similar to what you see in people with Child-Pugh A liver disease. And so in the end, for patients who have B7, B8, have a bilirubin of less than 3.0, don't have refractory ascites, these are patients that I would consider Nivolumab in. Seraphinib is also not an unreasonable option based on the Gideon study, as we see here. And you can see that overall the rate of AEs and the tolerability was reasonable with Seraphinib as well.
Yeah, I think that, basically we have two therapies which have good data. We have real-world data from the Gideon study, as you referenced, in terms of Seraphinib being tolerable in Child-Pugh B patients, and we have data from the Checkmate 040 study, once again showing tolerability and safety in well-selected Child-Pugh B patients. I think the other thing to keep in mind is a Child-Pugh B patient isn't a Child-Pugh B patient, so it matters how you got there. I think well-selected Child-Pugh B patients without refractory, encephalopathy, refractory ascites, probably more a Child-Pugh B7 patient than a Child-Pugh B9 patient. I think the options of either Seraphinib or Nivolumab in these patients is probably reasonable. Obviously, unfortunately, limited trial data, limited data in general, but unfortunately something we commonly see in clinical practice. So, last couple of minutes, I just want to cover briefly an emerging multimodal approach that is interesting in the first-line advanced stage setting. So TT fields are an antimitotic therapy that cause cell arrest. They work by alternating electric fields that can disrupt charged particles during mitosis, once again causing cell death and dividing cancer cells, but fortunately spare quiescent cells. And this, once again, has some interesting data that are coming out in different cancer types, including HCC. So to learn more about this mechanism of action for TT fields, we actually have a short video that we can watch now.
In metaphase of cell division, cells are a rounded shape as the mitotic spindle forms. Intracellular components such as macromolecules and organelles are naturally charged. Tumor-treating fields, or TT fields, disrupt cancer cell division by physically interacting with molecules required for mitosis. When alternating electric fields are applied to cancer cells, they disrupt microtubule polymerization. Tubulin dimers align with the electric field and are not able to form microtubules. This prevents the organized assembly of the mitotic spindle required for normal cell division. The inhibition of microtubule formation leads to metaphase arrest and cancer cell death. In addition, these deformed microtubules can lead to abnormal DNA segregation between daughter cells, which also results in cancer cell death. TT fields can also affect cells after metaphase. If a cancer cell has passed metaphase and enters the cytokinesis phase, the cell takes on an hourglass shape. This state under TT fields creates a non-uniform electric field inside the cell, creating dielectrophoresis. Net forces push the macromolecules and organelles toward the mitotic furrow, and this disruption leads to structural disorganization and cancer cell death.
And I think one of the things that's interesting about TT fields is that it's really cancer specific. So, it's tuned to a specific frequency to decide which dividing cancer cell it will target. And so you can see here, for example, normal intestinal cells have a lower frequency, at 50 kilohertz, whereas, for example, HCC has a frequency of 150 kilohertz. So essentially, you can tailor this based on the cancer type that you're trying to treat. And it's because of this sort of tailoring is part of the reason why this, should have safety in terms of sparing, quiescent cells while still attacking the cancer cells. Now, this therapy was evaluated in the phase 2 HEPANOVA trial in advanced HCC, 25 patients treated with TT Fields plus daily Seraphinib, followed by CT or MRI every 12 weeks until progression, with the primary endpoint of overall radiologic response. And in short, here you can see of the 27 patients that were enrolled, you see a disease control rate of 91%, objective responses of 18%, and these numbers compare favorably to historical controls. Given these data, this is now moving into a phase 3 trial that's being planned with the new standard of care, as we discussed, atezolizumab and bevacizumab. So this now is being evaluated. And, interestingly, TT Fields plus atezolizumab and bevacizumab was granted FDA breakthrough therapy designation in advanced stage HCC. Now, this is granted breakthrough therapy designation. It doesn't mean it's approved. It just means that they are fast tracking, the trial enrollment and trial rollout to see if this early data is confirmed in larger clinical trials. So key takeaways from this first section: atezolizumab and bevacizumab is the new standard of care for patients with advanced stage HCC and good liver function. There are multiple emerging immunotherapy combinations that are being studied in the first-line setting, several of these being informed by promising phase 2 data. It's not all immunotherapy. We continue to have an important role for tyrosine kinase inhibitors. Seraphinib and Lenvatnib continue to have a role in the first-line setting, and as you'll hear from Dr. Goyal, we do have TKI therapies that continue to play a role in the second-line setting. And finally, as you just heard, we have emerging multimodal strategies that also appear promising and interesting that we should get data over the next several years. With that, I'll hand it over to my good friend, Lipika Goyal, who will be talking about tailoring sequencing approaches after progression on first-line therapy and advanced stage HCC, a practice update for us hepatologists.
Thank you very much, Amit. It's my honor and pleasure to be presenting with you and Anjana today. I'm going to be talking about Plan B. What do we do after atezo-bev? So we'll start with a case. We have a 67-year-old woman who has a history of NASH and was found to have a 9-centimeter HCC with right portal vein invasion. She was started on frontline immunotherapy. And while she was on atezo-bev, she had an episode of grade 2 immune-related colitis, which resolved with steroids. Then she was re-challenged with atezolizumab and bevacizumab and had a partial response of around 40%. And then at 12 months, she presented with disease progression with new metastatic disease. Luckily, her liver function was preserved, and she had Child-Pugh A disease. Her performance status was preserved, and her AFP was 198. We are dealing with in the clinic now where people do well on atezo-bev. Luckily, afterwards, their liver function is preserved, their performance status preserved, and they say, "Doc, what do you have for me for Plan B?" So luckily, we have multiple options in the Plan B setting. And how do you think about that?
This is where I engage my oncologist heavily. But no, you're right. This is, I think, one of the most challenging aspects is, you have this great first-line treatment, and then what do you do if it fails? So usually I wouldn't think of more immunotherapy. This is when I may think of switching to a tyrosine kinase inhibitor, or something with more more mechanisms of action like Cabozantinib would be things that I would be thinking about.
Yeah, I think, Anjana, I agree. I think that, the way that I think about this, and there's probably two different approaches here. There's the quote-unquote T-1 approach, where you just put atezo-bev up front, and then you go Seraphinib or Lenvatnib, and then you preserve, what used to be second-line therapies and move those to the third line. So Regerafanib, Cabozantinib, Ramaciromab all get moved to the third-line setting. Or you use what I call a grab bag approach, where you just put everything together and you choose whatever you think is best for this patient. And you can choose, Seraphinib, Lenvatnib, Regerafanib, Cabozantinib, or Ramaciromab if the AFP is greater than 400, not relevant in this case. But you can choose any one of those. And then the other therapy that is approved here is Epilimumab and Nivolumab, right? So accelerated approval in the second line setting, which you could also consider adding in here, because even though you've already acted upon the PD-1, PD-L1 axis, you add in the CTLA-4. I think honestly, this is a data-free zone. There's nothing that's actually been shown to be beneficial after atezo-bev, because we haven't had those trials or those data come out. So as long as you do something, the good thing is you're not wrong.
I agree. Well, can I throw a question back at you? With this immune-mediated colitis or immune-related colitis, I apologize. Although it resolved the steroids, would you feel comfortable doing dual checkpoint again?
It's a great question. So honestly, we know that when you have PD-1 and CTLA-4, you can have higher severity and sort of earlier incidence of these sort of immune-related AEs, and so that may give you pause in terms of considering the CTLA-4. I would argue on the flip side, even though they had the grade 2 immune-related colitis, they actually had a pretty good response. They had a partial response of 40%. So I think this would be something that you probably would need to talk to the patient about. This is somebody who had 12 months without progression. You had a good response up front, and so this is just really weighing that risk-benefit ratio. But I agree with you that the grade 2 immune-related colitis may give you pause in terms of considering the dual checkpoint inhibition, and you may consider the TKI therapy. Of course, you could also hopefully go on the TKI therapy and then save something for third line. So the nice thing is, as we have more and more effective therapies, we may be able to squeeze in more lines of therapy.
Yeah, I think this setting actually highlights the importance of the partnership that we all have with our patients. As both of you are saying, the importance of talking to our patients about this being a data-free zone. We have multiple different options. Talk about the side effects and the benefits of these different drugs, recognizing in the post-atezo-bev setting, unclear exactly what the efficacy is going to be, and then make a decision together with our patients with decision sharing. So this is a slide that looked very different several years ago because it was a relatively empty slide. And as oncologists, we're always very excited when we have busy slides for what the new treatment paradigm is in a disease and that we can offer our patients choices. So as Amit very elegantly put in the first part of this talk, there's atezo-bev in the first line and then multiple ongoing frontline immunotherapy trials, which we hope will offer additional options in addition to atezo-bev. And then for patients who are not candidates for atezo-bev, we also have Seraphinib or Lenvatnib. And then in the second line, as has been discussed in the discussion just now, we have multiple different TKIs, and we have the anti-VEGF2 monoclonal antibody, Ramaciromab. Now, that's the receptor. Bevacizumab is a monoclonal antibody against VEGF, which is a ligand. So Ramaciromab could also still be an option to consider. And then also we have immunotherapy options, as Amit discussed from the Checkmate 040 study, Nivolumab and Ippilumumab, combination of PD-1 and CTLA-4 inhibitors, and then single agent Pembrolizumab. So I will briefly discuss the data for Seraphinib and Lenvatnib, and then talk about the middle box here, the different TKIs and Ramaciromab, and then finally talk about immunotherapy. So the data for Seraphinib and Lenvatnib, Seraphinib reigned king for many years in HCC without any other drugs being able to beat it in terms of overall survival. It went up against placebo and showed an overall survival of more than 2 months. And then there was the Reflect study, which was Lenvatnib versus Seraphinib. It was a non-inferiority study, and it showed that Lenvatnib was non-inferior to Seraphinib. It did have a higher response rate, but overall it showed non-inferiority, and both agents became options in the front line. And then it's important to think about what the side effect profile is of these two drugs, because we're often in a situation where we're choosing between one drug or the other. And as you can see, Lenvatnib is quite a strong inhibitor of VEGFR2, and you see higher rates of the VEGF pathway-related AEs. So you see hypertension at 42%, and you see the proteinuria at 25%, compared to Seraphinib, where it's 30% and 11%. So in a patient, for example, who goes on atezo-bev, who has significant VEGF pathway-related adverse events, it might be a consideration that patient might potentially have fewer side effects with Seraphinib compared to Lenvatnib. One of the side effects that you see more commonly with Seraphinib is the palmar-plantar erythrodysesthesia, which is the hand-foot syndrome. So something to think about with Seraphinib. But overall, two good options in the post-atezo-bev setting if we do the T-1 approach that Amit talked about. Then what are the other TKIs we have? We have Regerafanib. So, one of the things when we have lots of options is we think about what are the eligibility criteria for each of these studies, and are there any biomarkers that help us choose between one or another? So we have clinical biomarkers, and for the Regerafanib study, it was tolerability of Seraphinib. In this study, it was patients who had radiological progression during Seraphinib treatment, and they had good tolerance of Seraphinib at least 50% of the dose, 400 milligrams once a day, for at least 20 days of the past 28 days. And in this study of Regerafanib versus placebo, Regerafanib did show an improved median overall survival at 10.6 months compared to 7.8 months with placebo. So this gained FDA approval in the second line after Seraphinib. And then, it's always important to look at real-world data too, and really appreciate our colleagues who dedicate their efforts to collecting these data. And what we saw with Regerafanib was that the median survival in a real-world study, the REFINE study, was similar, even actually a little bit better. It was 13.2 months compared to what we saw in RESOURCE, which was 10.6 months. The side effect profile of Regerafanib is something that's important to discuss with patients. The most common side effects are palmar-plantar erythrodysesthesia, or the hand-foot syndrome, diarrhea, fatigue, and decreased appetite. So you certainly see some GI side effects with this. But overall, with some good active management, you can help people get through managing these side effects. Regerafanib can be an effective treatment for patients. Now moving on to another tyrosine kinase inhibitor, Cabozantinib. Cabozantinib is unique because in addition to hitting VEGFR2, it also hits MET, and it also hits AXL. There's some data that suggests that maybe VEGF resistance resistance to VEGF inhibitors could be mediated through increased signaling through the MET pathway. So Cabozantinib was tried after Seraphinib. In anyone who had prior Seraphinib, these patients were randomized to either Cabozantinib 60 milligrams per day or placebo in a 2-to-1 fashion. And importantly, in this trial, people were allowed to have 1 or 2 prior therapies, which is different than most of the other trials of drugs that are available in the second line. And in this trial, patients did not necessarily have to have good tolerability of Seraphinib in order to go on to Cabozantinib. And this trial showed an improvement in median overall survival. With Cabo, it was 10.2 months. With placebo, it was 8.0 months, with a hazard ratio of 0.76, and this was a positive study. So Cabozantinib was shown to improve survival in the second or third line setting. And then finally, Ramaciromab. As I mentioned, this is a monoclonal antibody against VEGFR2. And in the REACH study, which was an all-comer study after Seraphinib in patients with advanced disease, that study was negative, but it was against placebo. But in a subgroup analysis, it showed that patients with an AFP greater than or equal to 400 had the most benefit. So it's one of the first instances that I know of in GI oncology where a subgroup analysis led to another phase 3 trial. And this was a REACH2 study, and it was indeed positive. So patients with HCC that was unresectable or metastatic that had an AFP of greater than or equal to 400 were randomized to either Ramaciromab or placebo in a 2-to-1 fashion. And Ramaciromab showed an improvement in median overall survival. The median overall survival with Ramaciromab was 8.1 months compared to 5.1 months with placebo. And overall, this gained FDA approval in the second line setting after Seraphinib for patients with an elevated AFP. Again, the biomarker here was AFP to be able to decide if they would be a good candidate for Ramaciromab. So now let's go back to our case. So again, this was a 67-year-old woman with NASH. She had a 9-centimeter tumor. She had right portal vein thrombosis. She went on atezo plus Bev. She had the grade 2 colitis. She had the partial response of 40%. And then at 12 months, she had progression. So we discussed what some of the options would be: Seraphinib, Lenvatnib, Cabozantinib, Regerafanib, or Ramaciromab. The only one I would say that I would not use in this case is Ramaciromab because her AFP was less than 400. But as Anjana and Amit, very elegantly described, any of these would be a reasonable option because it's a data-free zone. we often will do Seraphinib or Lenvatnib next, and then consider Cabozantinib or Regerafanib in the third line. So now going back to our patient who had the NASH and she was on Atezo-Bev, she ended up going on to Seraphinib next. And she had stable disease on Seraphinib, but then developed grade 3 hand-foot syndrome. The drug was held. She was re-challenged with Seraphinib 400 once a day. And then she tolerated that well for 3 months, but then had disease progression with an AFP of 365. So at this point, Amit, what would you choose for this patient next?
Yeah, so right now, basically, she was on Seraphinib. She had the hand and foot skin reaction. It seems like she did okay with the lower dose of 400 milligrams daily. So even though she had the hand-foot skin, it is important to remember that coming into the resource trial, they only required a dose of 400 milligrams daily for 20 or 28 days. So even though she had this, she technically could still get Regerafanib. She meets that Seraphinib tolerability mark. And there's data that shows hand-foot skin reaction actually is associated with better responses to both Seraphinib and Regerafanib. So I think that, this would be somebody who I think I would actually consider Regerafanib. And then the other one would be Cabozantinib. So Cabozantinib, once again, if I think devil's always in the details of how that hand-foot skin reaction was and how the patient responded to that, how sort of, averse they may be to having that again. So I think those are the two TKIs I would probably consider at this point. And then once again, we've previously mentioned the Ippy-Nivo. And so, if this patient now has had, milder immune-related colitis, more severe hand-foot skin, this would be something I would discuss with them. But you may consider Ippy-Nivo as well at this setting. So I think you have 3 options that strike me as being on the table.
Yeah, absolutely. And how about dose reduction? Would you start with full dose Regerafanib or full dose Cabozantinib?
At our center, we don't typically start at full dose. And this is somebody where, particularly with the hand-foot skin reaction, we'd even do that more. But we typically start at a lower dose. So for Seraphinib, we start at 400 daily and titrate up. Same thing with Rigo and Cabo. We start at a lower dose and titrate up. This has actually been shown in colorectal cancer to be a very viable strategy of starting low and titrating up. And as long as you titrate up, I think you achieve, similar, if not better outcomes actually, with some of the TKIs in HCC. So our standard practice is to start low and go up. Anjana, what do you do in your setting?
No, I absolutely agree. And I think especially since she's already gone through 2 lines of therapy, you want to maximize effect for as long as you can. So absolutely, I agree with what you both said.
Yeah, and I think actually now in the Regerafanib Pembrolizumab trial after Atezo-Bev, I think they're using this strategy where you're starting with a certain dose of Regerafanib, and if the patients tolerate it, going up on the Regerafanib.
Yeah, and I think, with the combinations, when you're combining with the immunotherapy, given the fact that you're not necessarily trying to do all of the TKI effect, you're really trying to be more immunomodulatory. I do think that, as we start to go through the combination, you may see that lower dose TKIs do work, but I guess that's sort of a separate discussion, but something interesting.
Yeah, no, I think it's a great point. So going back to case 2, in the second line, as we've discussed, we have these 5 different options. We talked briefly about different clinical biomarkers to choose between them. One thing our field certainly needs is even better biomarkers, whether they're liquid-based or biopsy-based or other biomarkers, to be able to figure out how do we choose between these 5 different options. And then in the third line, depending on what people got second line, you can also see that people have multiple different options, again, with different kinds of clinical biomarkers. So finally, I'll just briefly discuss the immunotherapy data. Again, these 3 trials were all done in patients who were previously treated with Seraphinib. With the Nivolumab trial, it actually also had some patients who were Seraphinib naive. The overall response rate with single agent PD-1, Nivolumab, or Pembrolizumab was similar, about 14 to 20% with Nivolumab, 17% with Pembrolizumab. And then with the combination of PD-1 plus CTLA-4, Nivo plus Ippy, the response rate was 32%, and Amit very clearly went through that data elegantly. Overall, Nivolumab, Pembrolizumab, and Nivolumab plus Ippy all got accelerated approval. On review, Pembro and Nivolumab and Ipilimumab retained their FDA approval. So in someone who has Seraphinib or even Lenvatnib frontline, these are 2 options that I consider for patients next. As Amit mentioned, when you do a combination of PD-1 plus CTLA-4, people do tend to have a higher rate of side effects, including a higher rate of immune-related adverse events. But luckily, majority of these patients, when you put them on steroids, the AEs resolve. And so, again, careful patient selection is important for this. When you look at the long-term results of Pembrolizumab and Nivolumab plus Ippy, you see the overall survival with Pembrolizumab was 13.9 months. In the Nivo plus Ippy study, that was a single-arm study, the median overall survival was 22 months. So what do we think about when we're selecting immunotherapy? Some of these have come up in the discussion, but first we think about, did the patient receive immunotherapy in the first line or not? So did the patient get Seraphinib, Lenvatnib? We're more likely to give people a shot at immunotherapy second line. If they got a Tezo-Bev, then we can consider Ippy-Nivo, or we can consider Ippy-Nivo possibly third line. If patient had rapid progression or intolerance to tyrosine kinase inhibitors, that would be also a good option, a good place to think about immunotherapy. If patients have increasing degrees of hepatic dysfunction, you can consider single-agent Nivolumab in patients with Child-Pugh B, as we discussed in the first segment. And then if patients have contraindications to anti-angiogenic therapy, such as non-healing wounds or active venous thromboembolism or bleeding complications, as in the case that Amit presented, immunotherapy would also be a good option for these patients. So in conclusion, we're very excited that there are many different options now for patients with hepatocellular carcinoma. We have a frontline option, atezolizumab plus bevacizumab. As we've repeated many times already in this segment, the importance of doing an EGD within 6 months of starting this therapy to make sure patients do not have untreated varices. There are many exciting ongoing frontline studies. The Himalaya trial was positive with Durvalumab and Tremelumimab, and we look forward to seeing the results of multiple other studies. And then for patients who are not candidates for these combination studies, combination regimens, we do have Seraphinib and Lenvatnib. And then we talked about a variety of other therapies here. Again, I would just emphasize the importance of doing biopsies and really trying to understand what are the biomarkers that predict response to these therapies. We know from different trials that not everybody who goes on Plan A is able to go on Plan B because they have, a deterioration of either their liver function or their performance status. And not everyone who goes on Plan B is able to get to Plan C. So it really behooves us to do our best to match the right treatment with the right patient as soon as possible so that we can give people the best shot right up front. Thank you very much.
Thanks, Lipika, for that exciting talk. To finish off our presentation today, we next will have Dr. Pillai presenting novel strategies for patients with early and intermediate stage HCC. Anjana?
Great. Thanks, Amit. So I'll be focusing on this topic and specifically looking at the role of the hepatologist as well as multidisciplinary teams in making these decisions as well. So we'll start with a case again. So case number 3, this is a 45-year-old woman with NASH with compensated cirrhosis. Her imaging shows an incidental liver mass. An MRI shows an 8-centimeter classic LR5 lesion with 2 satellite nodules, no vascular inflammation, no metastatic disease, and with Child-Pugh A and excellent performance status. So here we're going to think about what we could do for this patient. So everyone's familiar with the BCLC staging system, again, looking not just at tumor characteristics, but also underlying liver function as well as performance status. And so we're going to really concentrate on the stage B or intermediate stage, which is a very heterogeneous group. And level 1 evidence is for TACE. Level 2 is TARE as well as downsizing or downstaging to transplant. And that's really what we're going to concentrate on these patients. So when you look at the AASLD recommendations, this is from 2018, the question is, should adults with cirrhosis and HCC with T2 or T3, no vascular involvement, who are not candidates for resection or transplantation be treated with TACE, TARE, or external radiation. So the AASLD recommendation is that it is better or recommends to have local regional therapy in these patients versus no treatment, with TACE having the highest quality of evidence. And the AASLD, importantly, does not recommend one form of LRT over the other. Again, the quality, certainty of evidence is low, but strength is conditional. And again, the evidence is really for Child-Pugh A and highly selected Child-Pugh B patients. There's really no data to support local regional therapy for patients with Child-C or poor performance status. And finally, TARE, as far as TARE or Y90 specifically, just got FDA approved for HCC beyond the human device exemption that it was previously approved under. So results for this should be emerging, but right now they're limited. So this is looking at the 6 and 12 prognostic score for TACE. This is a multi-center trial from China that was published by Wang and colleagues in Journal of Hepatology. So this is a prognostic model. There was 1,600 treatment-naive patients that were characterized as ideal for TACE. Child-Pugh A to B7, again, excellent performance status, no advanced disease, no vascular invasion, no metastatic disease or tumor rupture, again, no significant decompensation, and 74% of these patients were BCLC-B. And they used what's called a linear predictor, so they looked at the largest tumor diameter as well as tumor number and categorized into 3 different categories. So less than or equal to 6, greater than 6, but less than or equal to 12, and greater than 12. And you can see on this graph that less than or equal to 6 had the best overall survival at 49 months, whereas greater than 12 had the least overall survival at 15.8, and that shows in both these charts. You can see to the right of the screen as well. Now, this is looking at SBRT, or stereotactic body radiation therapy, as an alternative to TACE. The first study on the left is a retrospective single-center study from the University of Michigan. So they looked at propensity score matching of patients getting SBRT versus TACE. There were 209 patients, 84 got TACE, and 125 received SBRT. Overall, they were matched, except the SBRT patients had slightly smaller tumors, so 2.3 centimeters versus 2.9, and the TACE patients had more active tumors, so a median was 2 tumors versus 1 in the SBRT arm. There was a longer follow-up for TACE, and this graph is actually looking at local control rate, and you can see that the SBRT group had a 1-year local control rate of 97% versus 47% in the TACE arm, and 2 years of 91% versus 23%. As far as grade 3 and 4 toxicities, it was 8% in the SBRT group and 13% in TACE. And importantly, though, there was no overall survival difference between the 2 groups. Now, the second study on the right is a meta-analysis of 25 trials. Again, this is 11 of those were randomized controlled, looking at TACE and radiation therapy versus TACE alone. Again, unresectable HCC. And so you can see that, again, the graphs on the right show this quite well, that the combination arm of TACE and RT had a survival of 22.7 months versus TACE alone, which was 13.5 months. And importantly, you can see that the survival benefit actually progressively increased from 2, 3, 4, and 5 year respectively. So this next study, Kudo and colleagues look at this proof of concept study looking at Lenvatnib versus TACE in intermediate HCC. The idea is to use Lenvatnib first rather than traditional TACE, and these are patients that have multinodular tumors and beyond up to 7, but unresectable and no vascular invasion. There were about 30 patients that were actually enrolled in this final analysis, and you can see that the Lenvatnib arm is the one in the dark blue and the TACE is the orange, and the Lenvatnib arm actually had better overall response rate, and this graph is showing overall survival at the end of the study was a little over 37 months versus 21 months in the TACE arm. There are ongoing phase 3 trials, the ABC-HCC trial, or the Atezolizumab plus bevacizumab versus TACE, an intermediate stage HCC that is recruiting, and the primary endpoint is time to failure. And then the Regerafanib plus Nivolumab versus TACE, the Reno-TACE trial, the primary endpoint is progression-free survival. Now, looking at the concept of moving TKIs to earlier stage disease and the rationale for this, we do know that modalities like TACE, which is essentially cutting off the blood supply of the tumor via the hepatic artery, really leads to hypoxemia of the vessel. Now, the theory is that because of this hypoxemia, you get these leaky vessels, and you have also an increase in HIF-1 alpha and VEGF, among other cytokines that increases angiogenesis, which can in turn lead to tumor growth and metastases and more anti-apoptotic proteins. So the idea is using TKIs earlier can hopefully, quote unquote, normalize the vasculature and change the microenvironment so that you have less leaky vessels and less central hypoxemia. These are several of the trials that looked at combination of TACE and systemic therapy, TKI specifically, to look at that concept. There's 5 trials here. All of them, unfortunately, were negative studies, except for the phase 2 tactics trial, which looked at TACE plus Seraphinib versus TACE alone. Now, in this trial, rather than overall survival, they did look at progression-free survival, and these patients had a significantly improved progression-free survival, although there was no change in the overall survival. Although this trial had probably the longest overall survival compared to the other trials, one of the reasons that we think that these trials tend to fail is because you need quite some time to get good overall survival data, and as patients have adverse events or failed therapy, the idea is the control arm is most likely getting more active treatments, and that's why it's harder to show that difference. So the next wave in local regional next wave was really the idea of local regional therapy plus immunotherapy. And this, I'm going to concentrate on the slide on the right, or the graph on the right, which is by Duffy and colleagues that was published in the Journal of Hepatology. This was looking at Tremelumimab, which is an anti-CTLA-4 inhibitor, and ablative therapy, either with radiation or chemoembolization, radiofrequency ablation or chemoembolization. And in this study, most of these patients had hepatitis C, and they were given Tremelumab infusions, and after that course of infusions for a subset period of time, then had the local regional therapy. And you can see that they measured a few things, including CD3 and CD8, and you can see that responders actually had higher CD3 and CD8, that's the light blue graphs. And you can also see on the far right that the tumor post-treatment shrunk quite a bit, along with a decrease in AFP levels. And so again, this is highlighting the area of the abscopal effect, which is that there's regression of tumors outside of the field of radiation. So and the idea is these CD8 cells actually increase that, the idea of ongoing response, peripheral immune response. So we still have a few questions to answer about this, specifically which local regional therapy would be more immunogenic, what is the optimal timing of checkpoint blockade relative to LRT, and importantly, we need biomarkers to predict these responses. These are ongoing trials of immunotherapy with LRT. I'm not going to mention all of them, but there are at least 7 or 8 on here. These are, again, patients that are unsuitable for curative therapy, whether it's surgical resection, ablation, or transplantation. And most of these treatments you can see, or these trials, have systemic chemotherapy with either TACE, and a few have TARE as well. Now, so back to our case. So again, we have this 43-year-old lady with compensated NASH cirrhosis and an 8-centimeter LIRADS 5 lesion, 2 satellite nodules, no vascular invasion. So the question really would be, Amit, given this data, what do you think is a reasonable approach for someone like this?
Yeah, Anjana, when I take a look at this patient, there's a couple things that I really note. The first is that, as you said, that her current tumor burden, her largest lesion is 8 centimeters. There's the 2 satellites. And unfortunately, this puts her outside of UNOS downstaging criteria. And so even if she did have a response, we would not be able to get exception points for her for liver transplantation. And I think this is notable because she's 45. This is a really young woman who's developed HCC. Now, just because she's outside of UNOS downstaging doesn't mean she can't get a transplant. I mean, we could still try to see if she has a favorable response. And if that's the case, then she could be transplanted by living donor liver transplantation. And I would consider that in this case, particularly given the fact that she's so young. So that would be the first thing that I would really think about is what gives us the best chance at response. Now, I mean, you went through all of these exciting data in terms of, local regional therapy and then us shifting to considering combination therapies in the future. Unfortunately, outside of clinical trials, this isn't standard of care right now. And so this is somebody where if she's eligible for a clinical trial to use the combination therapies, systemic therapy plus, TACE or TARE, I think that would be very nice in this case in hopes of shrinking her tumor burden and then considering her for living donor liver transplantation. If she wasn't eligible for clinical trials, then I think, obviously, we would otherwise plan to treat with LRT. And with somebody this size, we probably would consider radioembolization more than chemoembolization if she wasn't eligible for clinical trials.
Absolutely. We would do the same exact thing in our institution. And I agree, living donor, or identifying a living donor for this young woman would be the best outcome. And again, the importance of a multidisciplinary team here, really collaborating with your interventional radiologist as well as your oncologist based on what her response is when she gets local regional therapies, whether or not she's able to be effectively downstaged, as you said. Perfect. So now I'm just going to kind of switch gears and looking at earlier stage. So again, looking at this modified BCLC staging system, now we're looking at early stage disease or stage A. Again, it can be a single lesion, but up to any size, or 2 to 3 lesions, all less than 3 centimeters. Again, preserved liver function, excellent performance status. So solitary lesions, if they're optimal surgical candidate, we move towards resection versus ablation. If not, transplant, and the same for 2 to 3 nodules. And the question is, what will we do to downstage? When we're thinking about transplantation for HCC, it is again reserved for unresectable HCC. It's the highest chance for cure, again removing the liver that often has cirrhosis as well as the cancer itself. And it is the indication, and HCC remains the indication for transplant up to 50% of centers in the US. And so there's a lot of different, ways that you can get when you have a B patient down to within Milan, which, as Amit said, is what you really need to get those UNOS exception points. So we have our next case, which is a 62-year-old man with chronic hepatitis B, again, compensated cirrhosis. He's on therapy with tenofovir, and while undergoing HCC surveillance, as he should, he was found to have a liver mass, and the MRI showed a 5.2 centimeter LR5 lesion in segment 6. He's again Child Pugh A, excellent synthetic function. Platelets are 217 and excellent performance status. So let's look at who benefits from hepatic resection. So guideline recommendations, really any, a single nodule, regardless of size, and anyone with that clinically significant portal hypertension, which is defined as less than or equal to 10 millimeters, plus platelets greater than 100,000 do the best, and as well as low bilirubin. The 5-year survival is up to 70%. Now, this is significantly less if you have clinically significant significant portal hypertension or elevated bilirubin greater than 1. So if we look at this graph on the right, you first have to determine, do you have portal hypertension, yes or no? And when you look at the no arm, you want to look at the extension of the hepatectomy. If it's minor, meaning less than 3 segments, or major, 2 to 3 greater than 3 segments. And then you look at the MELD score. And if the patient is very well compensated, the MELD less than or equal to 9, they're at low risk. So 5% risk of liver decompensation, and mortality is less than 1%. Whereas if the MELD score is greater than 9 and you have a major resection, then that's intermediate risk. So less than 30% risk of decompensation, but mortality now increases to 9%. Similarly, though, if someone does have portal hypertension and you're doing minor resection, again, less than 3 segments, again, it's that intermediate risk category. But if you have portal hypertension, you have major surgery, really it's very high risk, and mortality jumps to 25% or more. So in these cases, it's really important to also look at the future liver remnant, or FLR. In a normal liver, you want at least 20% or more, but in a patient with cirrhosis, you want up to 40% or more FLR. And also in a patient with fibrosis or significant steatosis, you also need a higher FLR than in a normal liver. The problem with resection, though, is the recurrence rate is up to 70% in 5 years, and we currently don't have any proven adjuvant therapy. So these are different trials looking at different factors associated with the outcome. Again, as I said, recurrence is 70 to 80% at 5 years. So if you look at the number of nodules, or the size of the tumor, if it's less than 5 centimeters, again, much lower risk of recurrence versus higher size, as well as the tumor-free margin, how far out, as well as blood loss. Now, the only trial that we have that looked at Seraphinib or adjuvant Seraphinib for HCC after resection or ablation. This was a phase 3 randomized double-blind placebo-controlled trial by Jordi Bruges and colleagues, called the STORM trial. And it was a multi-center, multi-country trial. They looked at looking for recurrence-free survival. Unfortunately, it was negative results. So this did not show that adjuvant Seraphinib actually had an increase, did not decrease the risk of recurrence-free survival. Now, there are several ongoing phase 2 trials for adjuvant immunotherapy. Again, these are all patients with high-risk characteristics, as I pointed in the previous slide, or high-risk characteristics and pathologically. These are all Child-Pugh A patients. So these are the 4 trials that are currently ongoing in this arena. So we go back to our case. So our 62-year-old gentleman with the 5.2 centimeter Leirat's 5 lesion undergoes a very successful robotic liver resection without complication. Unfortunately, though, his pathology features microvascular invasion and poorly differentiated HCC, which we know have both independently and together have a high risk of a recurrence. So he comes back to clinic, and the question I have for my colleagues would be, what are your options? How do you actively surveillance this gentleman? And what do you think about clinical trials in this setting?
Yeah, Anjali, see, you brought up the fact that, like, after surgical resection, all of these patients are high risk for recurrence, approaching that 50 to 70% at 5 years. And particularly given the these pathologic features of microvascular invasion, poor differentiation, this patient's at that higher end of that risk spectrum. And so, this patient, once again, would be a perfect patient for a clinical trial in terms of, adjuvant therapy, and somebody who likely would benefit from, consideration of one of the adjuvant trials that is currently ongoing. Independent of that, once again, he would warrant close monitoring. Our typical practice is to do CT or MRI-based surveillance after surgical resection every 3 months for the first year. And then we spread out to every 6 months using CT or MRI thereafter. Given the high risk of recurrence even years after, we actually continue CT or MRI-based surveillance and don't return back to ultrasound-based surveillance in this high-risk group.
Absolutely. Again, we do the same thing. I agree with you. We don't return to ultrasound. We do lifelong surveillance in these patients, especially in the background of cirrhosis, as you mentioned. So Lipika, what do you think about this besides surveillance?
Yeah, I completely agree with Amit that having this patient consider a clinical trial would be a good idea. They have the 2 high-risk features, as he mentioned, and there are multiple ongoing adjuvant trials right now of single agent PD-1 or PD-L1 or combination of PD-1 plus VEGF inhibition. So I think consideration of any of those, we want to obviously give our patients the best chance of cure, and given the data in melanoma and other cancers, I think considering adjuvant immunotherapy trials is a good way to go.
Excellent. Thank you. So I'm just going to wrap up my talk, just to have the last 2 slides. So this is looking at neoadjuvant strategies. So this first trial on our left is a single-arm phase 1b trial looking at Cabozantinib and Nivolumab. There were 15 patients that were enrolled. And you can see that there was, so these are patients that previously were deemed unresectable and then got this combination therapy and then became resectable. So 12 of these patients underwent resection, had margin negative resection, and you can see that waterfall plot on the right. And then when you look at disease-free, you can see that the patients that underwent the neoadjuvant therapy actually had more pathologic response versus non-response. And then this is another study that is not yet recruiting, but it's Atezolizumab and Bevacizumab before surgery for the treatment of resectable liver cancer. Again, this will be resectable HCC Child-Pugh A patients, and we'll have an N of 30 patients. And primary endpoint really is safety and tolerability. And then finally, this is looking at Durvalumab and Tremelumab for HCC in patients listed for liver transplant, Child-Pugh 5 to 7, ECOG 0 to 1. Again, looking at Durvalumab and Tremelumab, and these patients have to have a minimum of 72-day washout from the end of immunotherapy before they can undergo liver transplantation. And then the primary endpoint here is cellular rejection. So in conclusion, there are several ongoing clinical trials testing the benefits of systemic therapy in combination with other modalities in intermediate and early stage HCC. Again, multidisciplinary care is really crucial in patients with intermediate and early stage HCC, and I would say all patients with HCC. It's very important to collaborate with your oncology and IR colleagues to make sure that you're really providing optimal individual-based treatment and timely treatment for your patients.
Thanks, Anjana. That was really great to hear all of the exciting advances that are ongoing in the intermediate and early stage setting. I think it's nice to see that some of the exciting data we've seen come out in the advanced stage setting with the immune checkpoint inhibitors is now being applied in these clinical trials to earlier stages of disease, and hopefully we can even see more improvements in the future. Before we conclude the program, I think it's a good opportunity for us to take a look at some questions from the audience. We've obviously covered, once again, the very exciting data from IM-Brave 150, which showed improved survival compared to Seraphinib in the advanced stage setting. But I think whenever we apply this to clinical practice, we have to think of the inclusion and exclusion criteria for that trial and ask, can we use this or should we use this in patients that are in front of us? And notably, this trial excluded patients with significant thrombocytopenia, excluded patients with daily NSAIDs, and required an EGD within 6 months for all patients. So can I ask, Lipika, Anjana, how are you operationalizing these inclusion and exclusion criteria for the patients you see in clinic? And most notably, are you requiring an EGD within 6 months for all of your patients before going on Atezo and Bev?
Yeah, certainly it's good to follow the trial criteria as much as possible. For EGD, I do an EGD on all of my patients who are going on Atezo-Bev. I'm a little more liberal. I say sometime within the last 12 months. If they have new portal vein thrombosis or which could be from tumor or could be from, could be bland. But if they have new portal vein thrombosis, I'm more likely to recommend it within 6 months just to make sure that there's no new portal hypertension with varices. But otherwise, within 12 months has generally been my practice. With NSAIDs, it's a good question. Of course, there's always an increased risk of bleeding with the bevacizumab. If we can replace the NSAIDs with something that's not a non-steroidal, such as narcotics, for example, or something else, Tylenol, where they can avoid being on daily NSAIDs, I do that. But ultimately, HCC, unfortunately, is a life-threatening illness. And so with the data that we have for Atezo-Bev, I try to just monitor people carefully and proceed.
I am an EGD believer. I think in these advanced cases, it would be different if we were talking about early disease, but in these advanced cases, I think it's really hard to use the Baveno criteria, for instance, what we use for when we use EGDs, or when we should do EGDs. Some of these patients, most of these patients have normal platelets, and, there's also we have data that shows that some of these patients that have elevated platelets, right? Because it could be a paraneoplastic thing. But more importantly, I think when you have, even with advanced disease in Child-Pugh A, they still, about a third of these patients have high-risk varices. And there are trials that have shown that. So I am a stickler to this. I do get an EGD within the 6 months. And then it just helps me kind of figure out how they'll do long-term. I don't necessarily I will treat them once I find the findings. I don't necessarily just look at the EGD and check it off and not do anything about it. So I think you have to actively treat what you see. But yes, I do.
I like that. I'm going to call myself an EGD believer too. And so, I think that you brought up several important points. I think first, Baveno hasn't been validated in HCC patients, and so we don't know if the FibroScan results would sort of apply to somebody with a tumor where you may not have the same accuracy of those findings. And then you brought up also the platelet count issue. And so, we don't know if those criteria can be just applied to HCC patients and use those to see who doesn't need an EGD. And then, Lipika, you brought up the portal vein invasion or the portal vein thrombus. And, in the I Am Brave 150 trial, that was actually one of the risk factors for those people who actually had variceal bleeding despite having the EGD up front. Those were largely the patients who actually still had some evidence of GI bleeding. And so I think it is critical that we do the upper endoscopy for these patients before putting somebody on Atezo and Bev. The trial was actually accompanied by a nice editorial by Katie Kelly in the New England Journal that stressed exactly this point. As we discussed earlier in this presentation, I think part of the reason why this combination was so well tolerated in this population of patients with cirrhosis and HCC was because of the selection criteria, and we can't get lazy as we apply this out to, everyday practice. We have to keep up that rigor of doing that upper endoscopy. Another question that I see coming in from the audience, another good question, and Anjana, you alluded to this in your presentation. In terms of this LRT versus systemic therapies. And I think, this used to be two silos that were very separate. And now it's getting much more gray zone material where it's becoming harder to know, should this patient go on systemic therapy up front? And if somebody starts on LRT, when should they transition to systemic therapies? So what factors do you take into account in your multidisciplinary team in terms of when do you transition from LRT to systemic therapy?
I think that's a great question, and you're right. I think there's a big gray zone now rather than siloed. You must progress from one to another, and we do combinations in our tumor board as well, or recommend combinations in our tumor board as well. I think the most important thing is, what is your endpoint? That's what the first question I always ask is this someone that's ever going to be downstage to a curative endpoint like transplant or resection? That's one. So if they could be, then I'm more likely to use local regional therapy more proactively, as well as looking at their Child-Pugh function, obviously, and their performance status. So if there's Child-Pugh A and they have let's say a large dominant lesion, but may also have two other lesions in the other lobe, I would still use local regional therapy, even though that is multifocal HCC, and you can technically say it's systemic therapy, but if they have, let's say 5, 6, 2-centimeter lesions kind of throughout, then I'm more likely to use systemic therapy. So I really think it depends. And then also if there's vascular invasion or not, and the extent of vascular invasion. So I think there's several factors, including measuring, number of lesions, if it's bilobar or not, if it's infiltrative or not, if it's well capsulated, if it has vascular invasion. And I still think at the point where we're at now with systemic therapies, if you have a favorable outcome, you can still go back to and use LRT again, as long as the liver function is preserved.
Thanks, Sandra. That was great. So, Lipika, I imagine as the medical oncologist on this panel, you're going to say systemic therapy for all.
Indeed, Atezo-Bev for everybody.
yeah, exactly. So, like seriousness, I think Anjana laid out a nice framework. But how do you approach this in your tumor board? Anything that you do differently in terms of LRT versus systemic therapy and this transition for somebody who starts on LRT? When is the right time to go to systemic therapy?
Yeah, that's a great question. As Anjana laid out, I think about, are they on a curative intent pathway? If they are going towards transplant, I try to stick with liver-directed therapy. Right now in our center, we're not using checkpoint inhibitors for people who are going towards transplant. So for those people, I don't transition to systemic therapy, generally speaking. Otherwise, for people who have BCLC stage B disease, who have multifocal disease, who are unlikely to be on a curative intent pathway for whatever reason, I do think about what is their liver function and what are the systemic therapies we have available. Before, when our only option was Seraphinib, Seraphinib certainly was better than placebo, and it was a good option for patients who had systemic disease. But, given the side effect profile and the efficacy profile, I did try to push liver-directed therapy for a long time. Now that we have the Atezo-Bev data, I certainly want to give people a chance at Atezo-Bev. And I want to make sure their liver function is in good enough shape to be able to go on to Atezo-Bev. So I think to myself, how many rounds of liver-directed therapy have they had, and what is the impact on their liver? And also, how well are they responding to liver-directed therapies? If they've had a couple rounds of TACE and they're continuing to respond, then absolutely. But if they've had a couple rounds of TACE and they, for example, are no longer responding, I think it's a good time to move to liver-directed therapy. To systemic therapy, sorry.
Yeah, I think that this is great. So, these concepts of TACE ineligible and TACE failure are really now, diffusing more and more into tumor board discussions and into the literature. We've heard a lot of the factors that go into this. Tumor burden, bilobar disease, the degree of liver dysfunction at baseline. These all are important as we consider this discussion of local regional therapy versus systemic therapy. When we think of the transition, it's really how is this patient responding and tolerating. So it's not, just a matter of did this patient have a decrease in the tumor burden, but did you see a decrease in liver function? Did you see a change in the ALB score? All of these things are becoming more and more important for us to assess at baseline and as somebody goes through therapy. And I think we're going to see more and more data come out about this and more algorithms that actually help us in terms of who's best for local regional therapy up front, who's best for systemic therapy, who's best for combination therapies, and when is the appropriate time to transition. These are the next big questions that we're going to have to tackle over the next 5 years. But these are all good questions to have because it means we have more options. It means we have more tools in our toolbox. So I would argue, this is all TBD. We have some of the baseline stuff, but an exciting time to be involved in the field. So, to conclude, since we're speaking at the AASLD, I think we do need to obviously, explicitly discuss how hepatologists fit into the management of HCC. And of course, I'm biased. As a hepatologist, I always think of ourselves as the quarterback. We're the most important person on that field. And so, I think that we have several roles here in the role of that patient. We obviously have to do things, coming into this. We have to perform screening. We have to make sure that that patient is diagnosed early because then we have curative therapies available. We have to educate our patients about liver disease and our HCC risk. And after a patient is diagnosed, it's not like our job is over. We have to continue to work and play a central role within that multidisciplinary team. And you can see that even represented on this panel here. We have 2 hepatologists that actually serve as the medical director of our tumor programs. And it's really, once again, with this idea that hepatology plays a central role in the treatment for HCC, not only from a transplant perspective, but also continuing to follow those patients through, continuing to monitor their liver function, and really being the voice in the room that can act as that independent sort of negotiator in terms of these discussions between local regional therapy and systemic therapy, Often as the hepatologist, we have known that patient the longest, we know that patient arguably the best, and we can once again help that patient through this journey as they go from one therapy to another, hopefully getting better and better at finding curative options for more and more of our patients. So with that, I'd like to thank everyone. I'd like to thank our panelists, Dr. Goyal and Dr. Pillai for joining me today for this exciting presentation as well as discussion. I'd like to thank the audience for joining us virtually for this last hour and a half. I'd like to remind people to please complete and submit your post-test evaluation for credit. And once again, you can remember to download the slides and the practice aids as well as apply for CME credit by visiting peerview.com, HCC Live 21. And once again, thank you for joining.